this is our agenda. For the 2 hours we'll be together. So just doing some welcome and land acknowledgement, and then talking about sort of how we want to use our time together moving forward for the next couple of sessions that we have. And then we'll be spending, like last time, about 45 minutes in our work groups working together, and then coming back together as a general group to do a report out on what we discussed in our work groups, and then of course have open discussion before we're talking about next steps. Next slide, please. So I just want to start with our land acknowledgement. We would like to acknowledge that what is now Colorado includes the lands of the Ute, Arapaho, Cheyenne, Diné, Lakota, Apache, Puebloan nations, and many tribes, and that the sovereign tribal governments of the Ute Mountain Ute and the Southern Ute Indian tribes still reside in this state. These tribes are the original stewards of these natural areas. We want to take a moment to honor and respect these original stewards of the environment and their relationship with the land. Thank you. All right, so we are going to move on to talking about data. If I haven't already introduced myself, my name is Issei Yerdao. I'm the Senior Director for Data Analytics and Health Equity at the Colorado Hospital Association. We are a member organization that represents the needs of all hospitals here in Colorado. So we have at least 100 acute hospital members here in the state of Colorado. So we think about healthcare from a statewide perspective as well, and we cover all of Colorado. So we know that there's differences in the care that's being provided across the state. My main responsibilities at the association are to manage our data analytics group. We get a lot of data from our hospitals, and so we try to look at the data to see where care is being provided, what care is missing, and sort of what improvements we can make. And then recently I have taken on a more official role around health equity and trying to just understand what are opportunities that hospitals have within the data that we can at least see, and of course with engaging with our community around improving health disparities and going towards health equity. So we're trying to make sure that we're at the table to have these conversations so we can partner in creating solutions for all of our community members. And so that's a little bit about me. I've been with the association for 3 years, and so very passionate about data and health equity. So I will try not to get too nerdy on you guys today, but cannot commit to that because I get really excited about data. But moving on to the next slide. So in our discussions as co-chairs, one of the things we were trying to figure out is what is the best way to use our precious time over the rest of the year as we're getting together, and what kind of framework could we potentially provide to you all so that you guys are kind of thinking about the work that's ahead of you appropriately, or just kind of having a cohesion as we're sort of in our work group. So we thought that maybe using the CMS, which is the Medicaid and Medicare services, they have a health equity framework, and so aligning that with the work that we're doing might be helpful. And so our hope is that we'll spend each session that we're together on one of these priority areas, and the work groups will be discussing that priority area, and then we will come back together to have a discussion of kind of about how do we think that we can advance some of these priorities here in our state. So 5 priorities. The first one, which we'll cover today, is talking about standardized data, how we can collect it, report on it, do some analysis. The second priority is thinking about assessing causes of disparities within the CMS programs for them, but I think obviously will be for Medicaid and other programs here for us, and addressing those inequities in policy and operations to close gaps. So that's more policy related, programmatic, those kind of things, like what are things that we can put in place to ensure that we are going towards health equity. The third priority is building capacity within our healthcare services and workforce to reduce health and healthcare disparities. So that's really a conversation around diversity, equity, and inclusion. Does the workforce reflect the community that we serve? Like, how are we making sure that we have culturally competent care as we're providing care in the community?
I'm sorry, this is the interpreter. Would you mind slowing down just a little bit?
Yes, sorry. This is my first time working with an interpreter, so I have a lot to learn. So I will slow down. I already had my cup of coffee, so that's why I'm talking really fast. Okay, so the fourth priority area is advancing language access and health literacy and the provision of culturally tailored services. And so we will be talking about that in our fourth session, and things like how do we COVID-19 and language access will work together, for example, or maternal health, or access to care, those kind of things. And then the fifth priority is increasing all forms of accessibility to healthcare services and coverage. So hoping that we'll have really great conversation around all these priority areas. And of course, we want to start with the first section, which is the data collection. So next slide, please. There we go. So here is the full language around that first priority area. So just wanted to highlight what CMS is striving to do with this priority area, which is to collect comprehensive, interoperable, and standardized individual level demographic and social determinants of health data, or SDOH. So that includes race, ethnicity, and language, as well as gender identity, sex, sexual orientation, disability status, and of course, social determinants of health data, or SDOH. So as we're increasing our understanding through data collection of those persons that we serve, including their social needs factors, then we can actually come together and create programs that would improve that health equity over time. And so CMS wants to leverage their quality improvement programs and other tools to ensure that this is happening. And I think we can mirror that same thing here in Colorado to say, how does the data inform the work that we want to do? Next slide, please. So I tried to bring together the list of data sources that I know. I don't think this is comprehensive. I'm sure I'm leaving out a few. But in my line of work, working with hospitals, these are the different data sources that I've had opportunity to work with. And I wanted to highlight those different data sources for you all. So as you're going into your work groups, you kind of have, if you weren't aware, at least give them that opportunity. If you work at this entity or you're already well aware of it, then hopefully your conversations will be even more robust. So the current more statewide data sources that are available is the Colorado Department of Public Health, or CDPHE, of course, the Department of Healthcare Policy and Financing, HCPF, the Center for Improving Value in Healthcare, which we call CIVIC, and they're the all payers claims database. So what that means is, as a bill is being generated at any of those healthcare providers, like a physician office or a hospital, we call that a claim. As long as there is a payer affiliated with it. So if you are paying on your own, we can't see that data. But if there is an insurance provider or a Medicaid or Veteran Affairs, those kind of things, that bill, the Center for Improving Value in Healthcare, or CIVIC, they get a copy of that. So they have the most comprehensive sort of understanding of the healthcare services that are being provided. And I think what's even more unique about this organization is they can actually see payment. A lot of us can see what kind of healthcare services were rendered, but we can't see how much it costs the patient or the insurance company or the employer, but they can see that. So they really do a great job of highlighting access to care or sort of cost issues. We also have the Colorado Health Institute. They're sort of a research and evaluation nonpartisan organization that does a lot of surveying and doing a lot of reporting on different opportunities within Colorado, like childcare access or mental health, behavioral health, and we'll go through some of those examples. And the last two, Colorado Hospital Association, and of course, healthcare providers also have data. So there are a lot of wonderful entities here in Colorado, and I would say we have more opportunities than some states who don't even have organizations like this that are able to view healthcare data in order to understand opportunities for improvement. So with that, if we go to the next slide, what I tried to do is kind of try to provide some of the examples that are available to us. I think there's a slide before this one, Erin. Maybe? There we go. I try to provide some data examples within the different work groups that we have. And so starting with COVID-19 work group, I think a lot of us, I know for sure I was using the CDPHE data almost on a daily basis, both personally and professionally, just to understand what their rates were, were the rates of infection climbing higher, which counties were being impacted. So they had a lot of great data at the state level, regionally around COVID cases, as well as hospitalization. And during our pandemic response time, we definitely used that a lot to understand opportunities. And they had really great demographic information too. And so that helped us to really see where the disparities were existing in our communities. Of course, healthcare providers like CA and CHA, as well as HICPUF, can see utilization data related to COVID-19, who got care where, what are some other contributing factors that led to their diagnosis potentially, and what was the outcome of the care that they provided. Civic also was able to get data around telehealth utilization. We know for a lot of people going in to get in-person care, became really difficult, right? Because we had stay-at-home orders, or there were vulnerable population who really couldn't be in person. And so we saw a lot of telehealth services going up to bridge those gaps. And so they have a great telehealth analysis that we all can see. CHI also did work around postponed care. That was something that kind of emerged as we were thinking about COVID-19 response. They also did telehealth utilization as well as mental health. So there's a lot of information out there when it comes to COVID-19 here in the state of Colorado that's really useful, that we already have available to us as we're trying to think about a strategy to improve health equity as we think about COVID-19. Moving on to maternal health, there's also a lot of great resources here. CDPHE has a pregnancy risk assessment monitoring system that you can see data around tobacco use. There's a lot of great information about pregnant persons and sort of their outcomes around this. They will not provide it, of course, at the individual level, but you can get that summarized data available to you so that you can kind of see trends in your area. They also have Healthy Moms, a children's health survey. So they have a whole bunch of programs related to maternal health that you can leverage in an effort to understand opportunities there. Another organization that I wanted to highlight is CPCQC, which is a mouthful. It is the Colorado Perinatal Care Quality Collaborative, and they do a lot of quality improvement projects related to maternal health, and they always produce those reports as they're finishing those projects up. And so there's also data related to that. They've recently done studies on depression screening, on substance use disorder studies with birthing persons that are expecting, and then sort of the care that was provided in that and screening services. So in addition to CPCQC, is also other healthcare providers like HICPUF, CHA, that can also tell us sort of where care is being distributed, who is not maybe getting care, and those disparate outcomes that come as a result of that. I am going to try really hard to slow down, and I apologize for going really fast. Okay. All right. And so, sorry, behavioral health and prevention access to care. It's very similar information. Just wanted to let you guys know these are the different entities that are responsible and have opportunities to provide data for us. So just highlighting again that we have a new administration. I'm sure everyone knows the Behavioral Health Administration also just released their strategy around data collection. And I know they're really focused on making sure that there is interoperability, right? And so that as all of these different entities are gathering data, that they are talking to each other, and that that data can be made available to mental health providers as they're trying to understand opportunity for providing care and making sure that that care is equitable. So moving on to the next slide, I think so hopefully that gives some information around, where care is being provided, how that's being provided, maybe population health level data through our public health office. And so I think we have a pretty good understanding, hopefully now, of what those data sources could be. But as CMS pointed out, in addition to understanding sort of clinical implications or diseases, chronic conditions like heart disease or hypertension that might be affecting us at a population level, there's also social needs that we need to be thinking about and get data on that, because we know that social determinants of health they also have a major impact on someone's ability to lead a healthy life. So if we're not addressing those needs, then we're really not providing equitable care. And so within that framework, there's been a lot of work that's being done in the hospital space through incentive programs that HCPF has put forward that's really making hospitals take notice of some of these issues if they weren't having the ability to collect that information before. So just wanted to highlight the Hospital Transformation Program, or HTP. That is asking hospitals to do social needs screening and notification. And what that means is as patients are coming into the hospital, they will, in addition to other demographic data about them, like race or ethnicity or language that may be getting collected, they will also be asked additional questions like how their housing, if they have housing instability, if they have any food shortages issues, right? And then, or do they have challenges with transportation? Do they need help with utilities? Or do they feel safe at home? So these are some of the initial questions that are being asked. And so that information will be collected and then sent to the RAIs, which is the regional accountable entities, so that those RAIs can follow up with the patient to make sure that they are getting the services that they need. So this is being done in addition to all of that clinical documentation that's taking place in healthcare setting, which is really amazing. Hopefully, as this data is being gathered, over the years, we'll be able to see some of that trending data, and that would allow us to say, okay, we know someone had hypertension, but what else do they have? Do they have food insecurity? Do they have a lack of access to healthy food? Is that maybe the reason that they're not able to manage their hypertension very well? And what can the healthcare provider do in order to help meet that need? There's also another program called the Hospital Quality Incentive Payment Program, and that's HQIP for short. And they've done different programs throughout the years. The sort of the measures do change year over year sometimes. If we feel like hospitals are doing a good job of managing one quality program, that might be sort of archived and we start another one. So just want to highlight that in addition to the HTP program, this HQIP program is also in place, and that's looking at those demographic data and making sure that's being collected, and that staff at hospitals are getting education on why should we collect this data, because it's not always required. I always think back to when these questions were asked of me, and it's really hard to remember if that question gets asked consistently. Do I have the opportunity to self-identify? What's my ethnic background or my language of preference, right? And then that's actually very important to ask patients, how would they like to be communicated with? And so those two programs are going on. And then Joint Commission is an accreditation body. So hospitals have to be accredited by someone. They can sort of choose, depending on their resource availability, on who they want to accredit them, but they cannot be not accredited, right? And so Joint Commission does a lot of the accreditation for Colorado. So just thought that it was worthwhile to mention to this group that they now have a health equity requirement within their accreditation program. So hospitals must participate in reducing healthcare disparities, and there's other implications of this as well, in order to be accredited by Joint Commission. So I think we are really moving in that healthcare space towards having alignment between accreditation bodies, programs like CMS or HCPF, as well as payers and even hospitals themselves, to say we need to move beyond where we've been, and how do we actually collect the right type of data to understand the true opportunities that exist in terms of improving upon those health disparities that we know, again, have been documented for many years, but maybe we didn't really understand what the true reason was, right? We may just think, oh, a patient is just not compliant. They don't want to take their medication. Well, maybe the patient can't afford their medication, or maybe the patient doesn't have transportation to go get their medication refilled. Maybe the patient needs language interpretation services. There's a lot of the story that doesn't get captured currently within the medical record that really is telling a better story of what the challenges are that patients are experiencing and leading healthiest lives. And this sort of new data collection programs could help us with that. So lastly, just another program that's happening in Colorado, it is very exciting. It's called, the next slide, so I don't mess up the acronym, is the Social Health Information Exchange. And that's the interoperable part of this conversation that we're having around data, right? So there's all these different organizations, they're collecting a lot of data. It's really wonderful. Not all of us have access to that. There's kind of lots of hoops to jump through appropriately. But even then, the data cannot be matched at the patient level, right? So now patients are being asked these screening questions multiple times, and people are really feeling that fatigue of being asked these vulnerable questions all the time and not always getting the resources they need. So in order to sort of reduce some of that redundancy that exists currently in an effort to solve for these problems, this data is putting forward as Social Health Information Exchange. And that's coming from the Office of Health Innovation. And what they're really trying to do is connect all this data we just talked about: medical records, social care data, resource information, so that people can go to one place, hopefully, and have access to the necessary information that they need, either to provide treatment or to provide the referral. So if you're a food bank, or you're someone, a program that can offer rental assistance, you kind of need to know who is coming to you for that, so you can advocate for the right type of resources and financial support, likely, or staffing support, so you can address those needs. So really excited. I think they are right now in the process of figuring out how to best implement this, so that they can start rolling it out. So there's more to come. But it's always so exciting, and I always try to tell as many people as I can that this is coming. So if one of the challenges that you're identifying in your work group is, hey, the data is not talking, we're really hopeful in Colorado that in a short amount of time, the data will talk. So just know that that's happening. Next slide kind of finishes off. I took this slides directly from the presentation that they had given us. And so in closing with them, it's a two-pronged approach. Systems, whether they are referral systems or hospitals or clinics, they do not have to change their vendors. That's always a resource barrier. So this is vendor agnostic. So if you already have a system to refer, you're good with that, you can keep it. They really are working on interoperability and data governance. They're really trying to protect patients' rights and patients' privacy, and making what are the rules around that, rather than getting into the nitty-gritty of exactly what is the science behind the data exchange. And they want to build upon existing regional success. So like on the Western side, for example, they already have an integrated system. They're not trying to replace that. They're just trying to complement what is already happening and build upon the successful projects that are already happening. So like I mentioned, they want providers to stay in their preferred system. This is not meant to make anyone change anything or buy expensive software that they can't afford. They want to reduce duplication. I heard that just last week, that people are exhausted from all these screening questions that they're getting, and it's very intrusive sometimes. People don't even want to offer that. And so we don't want to make people feel even less like trusting of healthcare systems, because we're asking them if they have needs, and then we're turning around and not being able to provide the needs that they have, right? So we want to make sure the screening is happening where the intervention could also happen potentially. And then, of course, they want to reduce the burden of social care delivery, which I think is the next step in the evolution of the health equity conversation. So really exciting to see that this is happening here in Colorado, and we don't have to wait 5 years from now just to have the data talking to each other. So hopefully this will help us move into action much more quickly, rather than just commiserating about the data that's not going to. And so with that, I think this is the portion where we will, next slide. Opportunities. So I think we kind of covered that, right? There is demographic data that is being collected in hospitals and physician offices, but the data is not standardized, and it's not always required to be collected. So we certainly in our data sets do get unknowns a lot. because it's not a required. And some people don't feel comfortable to ask those kind of questions, even to say, what is your race or ethnicity? And so that kind of moves to the next point, which is there's not really a great standardized way to ask identifiable data in a respectful manner, right? So how do you even ask this question well? And so I think that the more training and understanding that we can have around how do we help people feel safe enough to answer this question truthfully and accurately, and they can understand that this data will not be used against them, right? Because there's a lot of mistrust when it comes to healthcare, because your race has been used or language against you before, right? In our long history here in the United States. And so I think that the better we can get at socializing this idea of asking this kind of questions that's safe and respectful, I think we can get accurate data to use. And then currently, of course, the data is not connected, right? So that's the evolution that we want to see happening, and we're hoping to see here in Colorado. So that was a lot of data talk. Hopefully that was helpful and will be helpful to you as you go into your work group meetings. And so I think that's where we're going to break next. So next slide, I think, has the questions to be answered. So if you have not finished your work group charter, now is a great time to wrap that up and make sure that that is taking place, that you feel confident about what your charter is. And then the 3 questions from today is discussing current data collection opportunities within your work group, challenges with the current data that's available, if any. And then if you had it your way, what would be an ideal data collection plan? So those are the questions that we have, and I think we will go into our individual work groups now. And Dana or Aaron, next steps beyond that?
Aaron, are you doing the breakout rooms?
Yep, they're already set up. And then
Okay.
Dana put all of the charters in the chat, correct?
Yes, I'm working on that. I think I have one more to get in.
Okay.
Let's see. That's the care. So I'm putting those in.
Great. And then also, if you need ASL interpretation, please join the first breakout. I think it's COVID-19. And unfortunately, we don't know where our Spanish interpreter is. We've pinged them to make sure that they can hop on. So once they join, we'll let you all know. So thank you for your patience.
Okay, did I get them all? And one more, I've got the COVID to add.
And just a reminder, we have behavioral health, prevention, maternity, access to care. And the last one would be immunizations/vaccinations. Before we hop into the breakout rooms, do folks have any questions, comments, or concerns?
Hello, everyone. I do have a question, Essie. So maybe this could be discussed amongst the larger group, but within my agency, we have been trying to review our intake forms and update our kind of the SOG data collectors. So I'm wondering if there's any kind of standardized definitions of some of those kind of markers that the SHIE is utilizing, so that whatever data we're collecting is reflective of this initiative.
Yeah, great question. I have not seen one currently that is, beyond. I think the 2 that I've seen is race and potentially ethnicity have been standardized, at the federal level because of like this census survey and those kind of things. But beyond that, really there are tools, of course, that can be used that have, been standardized, but not everybody's using the exact same tool, right? And so I think one of the challenges that the SHIE will face is mapping that out, right? And so I hope that when they're creating that sort of structure, they'll say, this and this will be mapped to this. And so we'll get some aggregated data, which is, I think, what all of us do is, right? We take sort of like these two data points are similar, so they mean this. So that's what I anticipate happening. But I think in any of these, organizations, I would think maybe CDPHE or HICPUC, those are great entities to say, then I'm rolling out something that I think makes sense for me. If others would like to adopt, that would be great. That would be my thought on that.
Thank you very much, Essie. I would say I've come across one peer-reviewed article that I kind of suggested to my agency, to where there is some research and data on updating EHR models to be representative and respectful of the LGBTQ community, for example. But to get buy-in to officially make these changes can be difficult sometimes. But I'd say I like it because it also guides and recommends a workflow on where and who asks these specific, very sensitive questions.
Yeah. And I think, sometimes as data folks, especially me, we go straight to intervention, but there is like a human aspect of this that really matters. These are not simple questions, like maybe your age might feel a little less, hard to give out at this time. So knowing who's collecting it, what situation, maybe the right time to ask these sensitive questions is not at intake, like right after, do you have insurance? And then how do you self-identify could be hard, right? So I think thinking about what is a good environment to ask that question, and how do we make that available? Because to be honest, in our data set right now, we collect sex, not gender really. So it's male, female, or unknown. That's really not helpful when we're trying to understand disparities. So there's a lot of conversations to be had around what is it, a new column or field to be collected that will be more expressive of how people see themselves and the needs that they may have that could be hidden beneath all of this, male or female or unknown category, that there's actually disparities that we have yet to see.
And I'll just piggyback on that really quickly. HICPUC is working closely with OHI on those data sets and capturing more inclusive demographics. So we're partnering with many organizations like CDC and One Colorado and Out Boulder, African American, or the Center of African American Health, and other stakeholdering organizations that have a great pulse on what are our members and the greater populations asking for. What can we do with their information? Because the first question is, why do you want to know that information? Is my data going to be protected? And so we are making changes to our Medicaid application. So once we get that rolled out, where Liz, to your point, looking at all the best practices and making sure that when we do roll out those changes that we're not causing more harm. And so we're also going to be offering training to our health professionals to make sure when they are having those care coordinators working with our members to fill out those applications that they're not being re-traumatized and feeling pressured to, make sure that they're answering specific SOGI questions. So everything's going to be optional. Jose, and then we're going to break out into those small groups. Go ahead.
Yeah, I think that in my particular group, it is kind of hard to use data collection beforehand, because one of our charges is to address as fast as possible, right? What's happening right now. What would be the expectation for us to data collect, and how, who will do it, etc. Because obviously there will be data. There will be data from the counties, there will be data from hospitals, there will be data from different providers, right? And even CCDs. But how to approach that?
Absolutely. Data is powerful. And so one thing that we have to be very mindful of is how are we leveraging that information? Because for us as healthcare policy and financing, it's really going to help us identify those disparities that are impacting our members and really having targeted interventions that are meaningful and not just making things up. So if we know that 10% of our Medicaid population are Spanish speakers, we need to make sure that we are providing translations and transcreations and interpretation services that are speaking to the language of their heart, and making sure that all of our applications and materials is transcribed and transcreated in a meaningful way that they can understand it. And so, Jose, to your point, we need folks like you and others to really recognize and tell us the best practices on what is meaningful to that population. Even just the granular nuances of terminology that can really make or break how we engage with populations, because if we say certain terms, it might create more distrust. And so what we want to be very mindful of is partnering with organizations that are historically not at the table. Individuals, thought partners, folks in the community that can really help us say, you know, here are the grassroots interventions and practices that have been taking place for 10, 20, 30 years. And it's not evidence-based, but it's promising practices that it's really making sure that it's making those inroads. So health literacy and other things of that nature. So great points, Jose. And as you all go into your breakout sessions, think about that question that Jose posed. How can we leverage that data in a meaningful way? So with that being said, I know we're kind of over time on our agenda, so I'm going to launch the breakout sessions right now. You should all see options to join. You can self-select. If you are ASL interpreters, please join the COVID-19. Looks like we need some folks to join prevention. So we have 3 folks in prevention. And then Dana, I'll just hop around as well.
Okay, and I'll do the same.
Okay. So we have 2 folks. So Katie and Renee, if you haven't already joined a group, there should be an option for you to select. So it looks like we have
Sorry, I went in the wrong breakout room.
oh no, you're good. All right, so we have the 2 interpreters in vaccinations. All right, I'm gonna take the liberty. See, I'm gonna move Katie and Renee. All right, So I'm going to pause the recording, Dana, and then we'll just hop around. And I think we're done at, what time does the agenda say? I should send out that broadcast.
45 minutes, but I know we started late.
Okay.
And I know, yeah.
So let's go with 10:25.
Okay, that should work.
All right.
All right. And you saw my meeting on the interpreter, my message.
About not utilizing language justice, not utilizing true mindful inclusiveness. And I know that Aaron is excellent on that, and if I having just an oversight, or maybe the interpreter can later, that can happen. But that's what I'm saying about inclusivity.
All right, folks, we're gonna come back together. Thank you all for your patience as we got our Spanish interpreter set up. So now that we're in the main room, if you need Spanish translation, please click the interpretation globe, select English, and you will hear the Spanish translation. All right, I'll turn it back to Essie.
All right, thank you, Aaron. I think this is the portion of our discussion where we'll have the work groups doing a report out on what they discussed. So, and it's only 5 minutes. So whatever you feel like is important to cover or most helpful to cover in a larger discussion in that 5 minutes would be great. So I will start with the COVID-19 vaccination group. If you guys are ready to report.
Thank you. I can go ahead and report out for our group. So I'm Sophia with CCHA. We also had Kaylan from Region 4, Ray, and then we had Julissa Soto, and we had Marius from HICPUP. So we just finished up the conversation around our charter and making sure to hone in a little bit more on some of our priority populations, identifying potential solutions and community investments. So in terms of priority populations to focus on, we talked about pediatric population, especially those 11 and under. We tend to see higher unvaccinated rates among that population. Also the unhoused population, just because by nature of them being transient and it's difficult to keep in touch with that population. So just how do we continue to maximize our efforts to serve those members? Also our Latino and immigrant community, Black and African American, and then some of our rural communities too. And then we also talked about how do we continue to have conversations to normalize the COVID vaccine within routine vaccine conversations and just the overall wellness. So making sure that providers are asking that question during well visits. So there is data that we have available now where we can determine if at time of well visit, a pediatric member was eligible for the COVID vaccine and whether or not they received it. So honing in a little bit more on those conversations. Oh, sorry.
Sophia, please, can you slow down a little bit for the—
Oh, I am so, yes, I'm so sorry. I was trying to fit everything in 5 minutes. So we just focusing more on normalizing vaccines within routine and wellness, and especially including the COVID vaccine in that conversation. And then I'll just go into a little bit of the data conversations that we've had. So HICPUF, like I said, has a lot of great data available that breaks
muy
down
bueno
where
que
people are getting
quiebra
vaccinated. And we're
en
also
que
able
está
to break
quebrando en
that down
dónde
by
están las
race,
personas
ethnicity, and
agarrando las
age.
vacunas.
So we had some conversations
Y
about
entonces
how
tenemos
we can
algunas
leverage that
conversaciones
data
sobre eso, de cómo
to
podemos
focus some
sacar esa
efforts, and then
información,
also,
y enfocarnos en eso, y también escuchar un narrativo de
experience and people's in the narrative doesn't always fit what the data is saying. So how do we make sure to leverage both when having those discussions? And then let's see here. We also talked a little bit about how some communities aren't even represented in the data. And so I think it's really great that HICPUF is starting to include some of that information in the application. But that's also can become problematic when someone doesn't see themselves represented in the data, and you know, how may not feel comfortable engaging if you don't even see yourself represented in the data. And then how do we focus those efforts a little bit more? Trying to think of what else. Anyone else from my group want to chime in if I missed anything important that you want to highlight? All right, well, that's all from the COVID group.
Awesome, thank you. Just reflecting on our conversations in the maternal health one, I think we're gonna see some really good themes emerge from this in terms of, you know, what does it look like for data collection and storytelling in all of these different groups, and how do we move more towards that comprehensive data collection, which includes accurate representation and making sure that the stories that people are experiencing are also being recorded somewhere, and that's being amplified as well. Thank you guys for that. I'm going to go to behavioral health next, if that is okay.
Alrighty. So we discussed several issues or kind of areas of improvement for the data collection. We did discuss how it needs to be, how it would be recommended to have like a centralized hub where a person can have all of their centralized information, and they can choose who to share that information with. I think somebody mentioned that Colorado is kind of starting to shift and go into that direction. We also discussed a lot of kind of barriers to care, again, on investing in the workforce, providing support, to expand the providers in the field, as well as barriers currently for people to actually become be part of the workforce or obtain employment due to, for instance, limitations on not being able to use marijuana medically or recreationally. We also discussed, let's see, other things that I may have missed. Michael, is there anything else that I'm missing? We discussed a lot of really rich information.
Sure. So we discussed the mistrust with the current data collection practices and the current uses of data, or like not how do I say this? Not using the data. And then we talked about challenges with questions and how like perceived bias can either affect answers or keep people from answering at all. We talked about rural regions and how they have real access challenges that would kind of prohibit staff from collecting data to the same extent as more populated areas. Then we talked about some of our like ideal collection plans, which is that new patients would have a standard set of questions for any new provider that they're seeing. And those questions would be based on the provider's role, like who they are, the desired use of the data, and the data that we have available. So we're not asking for stuff that's already been collected. Data would be stored in like a central repository, like we talked about for the state. And so multiple users could use that data based on their job role requirements. And we wanted to kind of like above, identify questions that people weren't comfortable asking, and consider how to ask that, whether it's like verbal and who asked the question. Did anyone else have anything they wanted to make sure was covered?
I did want to also just share with Chelsea's information or data that I think is so important to highlight in regards to barriers to care. She mentioned that I think in her rate 4, there's 1 behavioral health provider to 2,000 members.
Correct. So I can add in, we were looking as the Ray region, just kind of getting our health equity plans and kind of following this task force, what we need to do. So we were pulling data from the Ray, but then we also came across, there's a site, and I can find the link to it, that we were pulling, and it goes across the whole state of Colorado, and it breaks down by county. And for example, one thing we were looking at was behavioral health access, members to providers. In one of our counties, it's 3,920 members to 1 provider. And so we were looking at health equity lens, but also we just don't have the providers to cover the population size that we're serving. And so how can you focus on health equity when we just don't even have the access or the providers in our areas? And that's the same example for hospitals, physicians, etc. We're looking at these huge numbers to 1 provider. And so that's what we're trying to overcome in our regions. And then also transportation, how far is the locations, etc.
Thank you all. Yes, I think health equity is very complicated because it's complex, right? It's not a one size fits all solution. So if we just had this one technology, it would fix it all, right? Part of the issue is also workforce and ensuring that there is culturally competent, diverse workforce that's available, or even someone who's willing to potentially live in a rural setting. We were talking about that at a rural conference last week. That could provide care locally instead of the community being asked to go elsewhere to seek care, someone that they don't know or identify with. So I think that's one complicated part of the health equity conversation, is having the right workforce to provide that care, amongst all of the other things that you all also highlighted, which I will not try to go back through. But I think those are great conversations to be having, and hopefully we're all, again, just building towards some solutions we can offer collectively as a group to say, how can we address all of these together? So with that, maybe going to access to care next.
Thank you. I think one of the biggest things that we discussed was that, and Jamie said it perfectly, so I'm gonna look into my notes, that access equals experiences, and that's not what we collect in the data, and that's not, what we rely on. All those agencies that you listed at the beginning, they give us a good picture, but they don't give us the whole picture. And how can we really understand our communities and areas across all of Colorado without understanding experiences and collecting that information on a more regular basis? And so that they're knowing that there are surveys out there that do collect that information. They happen every couple of years, or it's random. And then also the mistrust of people not maybe wanting to give their information, and then providers not wanting to share that information as well, since it is personal information. But we need that to be able to provide culturally competent care and reach them where they are. So a lot of course, data issues with that, collection opportunities. We talked a lot also about digging deeper into demographic data that's available. So looking at, LGBTQ language, how can they access care that's where they are? And not only asking those questions, but asking, did we as healthcare entities across this group, did we reach them properly? Did they get what they needed out of healthcare? And so kind of digging deeper into that level of data that is being collected. Another component we discussed was training providers, community organizations, other staff members to understand how to collect that data and bring that trust into being able to ask those questions. One thing we discussed that happens in other states are like community coalitions. So there's leadership in those areas, rural, frontier, urban areas that understand the community and can advocate for their community, and they're a part of that community. And so getting those organizations or starting those organizations to better understand who we're serving at a deeper level, and a more individualized level. A lot of what we gather is population health based and trying to look at individual needs of members across the state. I'm looking back at my notes. That was a lot of what we discussed. I think it's all data that we understand that we need, and then thinking about how to utilize that and how to gather that data. And quantitative data isn't always helpful. It's helpful for us to understand outcomes in that way, but there's much more on the individual person, community groups, different populations that we also need to collect. So how can we gain trust and collect that data regularly to make impact on then the outcomes that we can gather from claims data and other data sources that are available. And please, anyone from my group, jump in if there's anything I missed or would like to add.
Not necessarily that you missed, but one thing that I mentioned in the last couple of minutes is that HICPOP has this data. With the governor's office, when we created the class, there was a subcommittee dedicated to this, and we brought experts from different universities in the country in order to help us think about how to convert qualitative data into quantitative data that we can use in real life, and that work is sitting somewhere in HICPOP or maybe the community living group, the community living office, and that we should look at it, because I think that for this is very pertinent. And also that two of the initiatives that HICPOP has initiated in two different areas called the ambassador programs are I think, have amazing potential and could be extremely helpful for us, because one of them is looking at engaging communities based on local leaders that they already trust as ambassadors, and not even including HICPOP in those meetings, but just having those ambassadors report back to HICPOP. And one of them is for the overall Coral Islands, the 1182 bill, and also for the notifications that Cesar was mentioning earlier. So I think those are excellent opportunities that we have to do something similar.
Awesome. Yes, I think we are all recognizing in each of our groups that stories matter and those stories need to be amplified. And that is part of the data collection, and they can't be overlooked because that's what has been overlooked thus far, right? And we probably use data to just sort of justify that things are fine when they're not fine at all. So I think being able to tell stories and making sure those are being heard is really important. Thank you for saying that. And then, yes, like ambassador, the community that you're trying to solve the problem for should be at the table while you're solving the problem. And gaining trust, I think that's another theme that we're hearing. And also making sure that, having people from the local leadership be the ones who offer solution, have those conversations, probably a much better idea than a state entity or someone executive coming to a local meeting and trying to, come up with a solution. So going to maternity health next, if that's okay.
Yeah, I can jump in here. Let me know if y'all can't hear me. I think there are a lot of consistent threads between our groups, as SA was saying. What a lot of things we talked about when it came to challenges with getting data related to maternal health is first and foremost, we want to ensure that pregnant people are able to get timely access to prenatal resources, that we're identifying them early in their pregnancy and making sure that they're getting the support they need. And we talked about, certain groups that might not be accessing that care early on, rural communities where there's a lot of maternal health deserts, people who might be experiencing substance use disorders and things like that. And wanting to understand, again, that qualitative piece of why is this happening? Why are we not getting this data early on? Why are people not accessing care in this early part of their pregnancy? And that comes in with that qualitative piece. We also talked about how there's a lack of specific data regarding births that happen outside of the hospitals. We know that a lot of facilities are collecting and have hospital data about prenatal and postnatal care and birth outcomes. And while we have some data about things like home births, yeah, I'm at the Capitol today. While we have some data about things like home births, we don't have a lot of the specific understandings of who is involved in those births. What does birth worker involvement, doulas and midwives look like, and more specifics about the experience that person had. The experience that that person had and the birth outcomes that might come from a home birth or a birth center. We also talked about how a lot of data collection is fully voluntary, and a lot of it happens through billing data. So we're not always getting data early on when we can access it in a timely manner and use it to be more responsive. A lot of times the billing is happening after the child is born, or just generally data collection is delayed. And so that lag means that we can't always use data to help us right there in the moment. And yeah, we talked a lot about collecting qualitative data. How do we close this feedback loop and understand what people are experiencing during the perinatal process? It's really important to both understand that, and then if there are avenues for sharing that experience, where is that going? Making sure that patients know what is the accountability, and making sure that providers and facilities know that who is going to be there to support them to make sure that they are providing the most affirming and positive care. Part of this is also identifying which facilities are doing this work, are providing really affirming care, safe, culturally competent care during this time. And making sure that that data is talking to each other, that we're seeing these positive examples, and that we're understanding, again, the why behind this, and that we're threading with that narrative, that qualitative experience of what people really, what's really happening there. We named too that having those positive, having that positive data, having data around home births, having data around doulas and midwives, for example, that positive feedback and data can be used to create more progress. We know that there's a lack of access to alternatives of care for folks to be able to give birth outside of the hospital. There's a lot of barriers to that, and we can really push decision makers to increase that access by showing how positive that experience is for folks, and show what the data really shows around birth outcomes and the health of the person and the baby. There's also some challenges when it comes to keeping connections within our data. Again, having data talk to each other when it comes to the mom and the baby. We didn't specifically bring this up, but I was just thinking about how we really need to treat the postpartum period, especially those few months after the birth, making sure that we're speaking about the mother and the baby as a dyad, as that is still a continuation of that experience. While they are not physically connected, they are still connected in every other way. And that needs to be maintained, and it needs to be reflected in our data. I think not always, the data doesn't always really reflect the reality. It's not completely neutral in that way. So there's challenges where you might be able to see that there's a baby in the NICU, but you can't connect it to see who the parent is and know what their experience is, and what they're going through during the postpartum period. There's also a lack of data when it comes to incarcerated people, just generally, but especially, you know, when it comes to perinatal data, how many people, you know, in jails and prisons are pregnant or are lactating, are people able to access lactation support when they're incarcerated? What are the birth outcomes for jails and prisons? That kind of thing. And then let's see. Yeah, we also talked about collecting data around providers and specialists to support members to engage more with specialists and for providers to be part of the conversation. I think really treating data as you know, an ecosystem and ensuring that supporting everyone, again, threading that narrative and that personal experience that people are having. So other folks in the group, feel free to add things that I missed. I tried to keep it kind of high level.
Thank you, Lauren. And lastly, we have our prevention work group report out.
Okay, yeah, a lot of awkward silence. Sorry about that. I guess I'll read the notes, and if you guys could help me out, that would be great. My team members. I had to use 2 devices so I could pull up the document on one. And okay, so we worked on the ideal data collection and challenges with current data available. I'm just going to read it from the top. Members may have a distrust of individuals who are asking the questions. Do members trust that the information they are providing will make an impact? So we want to see the results of our own input. That'd be great. The culture of the data collectors may inhibit members sharing information, which I probably need to think about a little bit more. Refugee community, Morella talked about that. There are gaps. Are we able to identify supportive supports of members in the data collection? This may relate to fraud, waste, and abuse. So I think that the death and birth doulas would be helpful because they treat the whole family. They'll get to see who is loving and caring, who's a little hostile, who's got money, who doesn't, who's willing to give a ride, who isn't. And they bring that together in a very beautiful, I mean, they don't have to, but some of them are very welcomed into the circle and create a circle for those conversations. So, but I think fraud, waste, and abuse does plague our system. We have a blind eye to it sometimes. And so there's a lot of training I've taken on that. There may be alternative treatments that members are using culturally that would not be covered in data collection. So Janelle from HICPUF, the Native American population, concurs with this route for collection of alternative treatments. And I brought up peer-reviewed articles are not available sometimes. And so because there's not peer-reviewed articles, the government can't consider them to be included. So we need to get a pipeline of data going with plants in our environment. Okay, challenges with time, the data lags in getting data in real time from Allie. Challenges of rural urban settings and types of data collected. Allie can talk about that too. Substance use data collection and SBIRT from Janelle. Ability to project and address provider workforce shortages. And with the substance use, I would love to see the 2-gen. I would love to see that present population. I'd love to see like the wraparound services that talk to the children and the support group. So like the group that's there with the birth and death doula, that group, I would love to see them included in some of that data collection to see where they support and where they, because it's a codependent situation sometimes. So Al-Anon. Okay, ideal collection plan. making sure that providers are trained on how to ask questions. So SDOH. Ideal to have a statewide training of how to ask questions. That's all by Allie. She could talk about that. Standardized consistency and data collection across the state. So that's where you're getting treated the same way everywhere you go. Members would not need to repeat their data multiple times to various providers. Data would be able to be transferred. So I read a book in college, 2014, let's say, and it talked about interfacing different databases and how we could house all of our medical through this, and it would follow us. And I think that's blockchain and stuff. It's coming. It might already be here. We just got to learn about it. So there's a way to like house all your data instead of each person having to provide their data, especially in a time of critical care or crisis, you know. And then we need, I don't know, I feel like police officers and school districts need to have access to critical data, including custody. That's just me. Let's see. Maybe back to the list. Standardized consistency of data collection across the state. Members would not need to repeat their data. Include alternative methods that work in data collection. So if it works to, you know, hand out a flyer at the food bank and manually enter it, or have a touchpad while people are standing in line, you know, whatever works to gather the data and get it input. So alternative methods that work. I think we might have to have like a general form. People collecting data that have a cultural understanding of members that they're speaking with so that they can have the heart-to-hearts. Capture a member's idea of what preventative care is. It may look different for different cultures. So just exploring that a bit. Capture provider disbursement throughout the state. And I don't know who said that, but I would love to learn more. I love to see budgets. And that's the end of the list. Thank you.
Thank you. Okay, well, we have about 3 minutes left, so maybe 1 minute for maybe general reflections, and then we're going towards closing out this meeting. Any thoughts from anyone in the group? General reflection? I don't do awkward silence very well, so I'm gonna move on. Oh, Jose, yes.
I would like to talk to you about the whole organization of this group, because I think especially since this is focused on health equity, and we want to be as inclusive as possible. I can help as part of CCDC to bring that to bear. And I know, Van, you are very open. We like you a lot. You are very open to this kind of conversation. So if you could please have a meeting with me later, I would appreciate it.
Yeah. Okay, thank you, Jose. I think in closing, just to be respectful of everyone's time, thank you for everyone that was able to join today. I know you all are very busy. This is very important work. Thank you for all that you do in your communities and your respective organizations to advance health equity. I know we heard a lot of the same themes today. Establishing trust and understanding who's collecting the data, where it's going, how it's being used is really important. Amplifying those stories that are not currently collected or shared is very important. So experience is equally as important as the quantitative data that's available, and making sure that's being shared. Using local leaders and trusted persons to advance these conversations or have these conversations be at the table, making sure we're understanding who's missing from the conversation, like persons who are incarcerated currently do not have all the services that they need provided. How do we make sure that that is also being elevated? Alternative medicine options, making sure that people are getting the type of care that they would like instead of what's currently being prescribed, right? And making sure that data is being collected on some of that alternative medicine or cultural care that's being provided to make that an option someday. So those are just a few of the ideas. Thank you so much for your time today. I think we will continue this conversation around the different priority areas like we talked about next time. And we will be in touch with minute notes. And I know Dana's been putting a lot of the charters and links in the chat. So please use those to finish the work that you're doing if you need to. So thank you, everyone. Appreciate your time today.